Okay, I'm going to mess up your conversation. I want to introduce our speaker. A lot of you maybe have never met Mr. Gordy, Joe Gordy, Flagler Hospital. I guess he is the main leader there, I understand. Reason Norm and I have had a real heart for the Flagler Hospital. We had a son that was spent a lot of time in Flagler Hospital. He shortly, a few years later, went to Gainesville and he passed away. But his wife just celebrated 25 years as a nurse at Flagler Hospital. Our daughter-in-law, his wife, she's still there. And we used to have our ministerial meetings monthly in Flagler Hospital in a conference room. And we got talking with, I don't remember who talking with, can we start a chaplaincy program in Flagler Hospital? And we got all the ministers that were there all signed up at that time. I don't know how many years ago it was. And they're still going. One thing that I was thrilled, I hadn't told Mr. Gordy this, I seen all of the signs out there parking for chaplains and ministers at Flagler Hospital. That was wonderful. That was not there before. We just had to find a place to park. Now they have a parking spot for us. And it means a lot to us when you have been connected with the hospital for years. But they never had a chaplaincy program. I was the type of person, I've got to be careful, I get emotional with this thing. I never dared to tell my son where I went home. He thought I was always in the waiting room. Because before he passed away, he needed Daddy. But chaplaincies, when they come in there and people would care for them. I just wanted to say that, just to really compliment Flagler Hospital to being a real blessing to our family over the years. And then, like I say, our daughter-in-law just completed 25 years as a nurse over there. So, Mr. Gordy, we're so proud to have you come and speak to us, to share your heart with us. We thank you for the leadership you've given us in the city. Well, let's welcome.
Thank you. I have to tell you, thinking about clergy spots, one of my very best friends in the world is the Reverend Dr. Carrie Hinckley, who some of you may know. And years and years and years ago at the old hospital, we had clergy spots, and one of the pathologists mistakenly parked in the clergy spot because he couldn't find a place in care. He put a note under his windshield that says, "For parking in the clergy spot, you're going to go to hell." And I have to tell you that doctor was so upset about that. He never did it again. No, it's wonderful to be here and see some of my colleagues from a long time ago. Pam Malarkey over there, besides running her own wonderful ministry that I support. She and I served on the school board together years ago, and we enjoyed each other's company then and still do. So I'm so good to see her, and nice to see you here today. Today I wanted to tell you about what's going on. It's really hidden news, and you may not really feel it, but I wanted you to know what's happening. Hospital CEOs all over the country, and we go to meetings and things and sit and talk. And we're all in the same boat. This is a time of so much uncertainty that nobody knows what the real answer is to reach the road ahead. But you have to make decisions despite that. And just to give you an example, everything that I'm about to tell you that we're now doing was something that I sat and envisioned myself, but also with the advice and counsel of my colleagues at the hospital about 5 years ago. because a hospital is a hugely complex business. And it's more like an aircraft carrier than a battleship. You can't just turn it around. You have to plan your turn well in advance. And some things are just the nature of what you had to do. You had to start 5 years ago or it wouldn't be happening now. So, and it's no mistake to say that what we are doing is fundamentally transforming the delivery of health care. And it's not just the hospital. It's the physicians. It's the home health agencies. It's the nursing homes. It's everybody involved in health care. And here's why. Flagler Hospital is 125 years old. And while that sounds like a really long time, especially since you helped us write a book for 125 years ago, good heavens. But to put that in perspective, Claude Weeks, Jim Konzemius, and I, if you add up all the times, and we're all still around, that's about half that time. So, it's a touchable history and a memorable history. But having said that, during all that time, more or less, the hospital and the doctors have been paid pretty much the same way. You do some kind of service, and you get some kind of fee for it. Now, it's changed up a little bit, but basically that's it. And so you do a CAT scan, you get paid so much from Blue Cross for a CAT scan or so much from Medicaid for a CAT scan. Now, you think about that, and I don't think there was anything venal about it particularly. It was more not thoughtfulness, let's put it that way. But during all that time, what does that encourage? It encourages you to do more, right? The more you do, the more you get. And certainly, that clearly it drives up healthcare costs. And the fundamental change that took place was this horrible recession we had and the collapse of the real estate market. Because in this particular community, now every community is going to be different, but in this particular community, all of the big employers are self-insured. That means they don't write a check to the insurance company for a premium. What they do is they hire an insurance company to process their claims. And once a month, the insurance company calls them up and says, send us $200,000 because that's what we spent. So you're funding it yourself. And yes, you ask your employees to pay a premium, but that nowhere offsets the total cost of what you're doing because you just couldn't raise the price high enough to cover it. So all of a sudden, all of those, especially the constitutional offices, including what Wendy's got there, and the county and the school board rely on property taxes. Well, what happened to the property tax base when the real estate collapsed? It collapsed too. So all of a sudden, and in the state as well. So what happened was all of a sudden, that little increase that you saw every year, the 2, 3, 4% increase in healthcare costs. And of course, I got to tell you, nobody sat there, we just didn't, and say, well, over the last 10 years, that's 25% or 50% it's going. Nobody thought like that. You just built it into the budget knowing it was going to go up 2 or 3% every year. Well, nobody can do that anymore. The hospital's self-insured. We can't do that anymore. Something's got to give. And that's the big changer because we already know that Medicare is going broke. They keep changing the year, but it's out there and it's going to happen, absent doing something very different. If we keep on doing what we're doing, it'll go broke. Well, that's always been the big elephant in the room. And the thing that was added to it was that the people paying for health care, the big employers, can't do it anymore. They can't afford the increases. Now, in this community, those are our partners and our friends. They're not just some anonymous business that we don't care about. I mean, I just said I was on the school board. I'm very close to Joe Joyner, the superintendent. I still care about the school system. I happen to start a foundation that's now very successful, not because of me, but I'm very close to the education in the school system, and I care about it. I don't want to have the hospital be responsible for taking teachers out of the classroom because they can't afford their health insurance anymore. And by the way, the school system right now is $11 million upside down on where they thought they were going to be paying for health care, and they don't know where to get the money. I mean, it's a big problem. So 5 years ago, or more maybe, but at least 5 years ago, knowing that this was happening, I realized that Flagler Hospital needed to become a partner and not a part of the problem. We needed to take charge of this because the county can't do it. The other people that are on the receiving end can't do that, but we can. And this is not an easy transformation. So, interestingly enough, at that very time, there was this article in the New Yorker that was written by the surgeon out of Mass General, whose name I can never pronounce, and so I won't even try. And you see him on CNN sometimes. He's at a One Day or something. I forget what his name is. He's a very sharp, bright guy. He wrote an article. He went to McAllen, Texas, and wrote where McAllen, Texas is a place that has outrageously high Medicare spending with no particular difference in result. And so he went there to see what in the heck was going on. And he wrote this article about it when it was not very friendly to the healthcare system down there because they were milking it, is what they were doing. And it was quite obvious. They were just doing stuff for the money. And then the New England Journal of Medicine, a couple months later, in sort of reaction to that, wanted to, I think they were motivated by the fact that they thought everybody was going to walk away thinking all doctors were like that. But they wrote an article about the healthcare system in Grand Junction, Colorado. Well, Grand Junction, I don't know how big it is, but it sits in a valley in the Rockies in western Colorado, and it doesn't have it's at least a 100-mile drive to Denver, so it's really kind of isolated. So it has a medical community that's self-contained. So they have one hospital. They used to have two, but now they have, at the time of this article, they have one. And the doctors don't really go anywhere else, and the people mostly use that facility. They can do pretty much everything. So maybe something real exotic, you'd have to go to Denver, but most everything you can do, you can get there. Well, what does that sound like? It sounds like this market. We have 200 and something doctors. They don't go anywhere else. We have one hospital. We have the hospital, and the physicians in that consolidated group feed the nursing homes, feed the home health. We have a hospice at the hospital. I mean, it's a self-contained medical community, just like Grand Junction. And the point of the New England Journal article was they have extraordinary low Medicare spending and excellent quality. And how'd they do that? So my number two guy found that article, and he brought it to me, and he said, you know what? We can be Grand Junction. And he's right. I said, you're right. Let's figure out what we have to do to achieve that. And here's what I'm not going to go too much detail, but what Grand Junction did was this. First of all, the biggest problem that we have right now is that everybody is working in their own silo. The doctors work in their own office, care about their own patients. It's not they don't care, and they're all very high quality, but that's their focus. And then you have another doctor over here doing the same thing. And maybe they're sharing a patient because one's a specialist and one's a primary care, but they don't know what each other is doing. There is no coordination of care. Once you leave the hospital, what we would do is you'd get a discharge sheet that told you, your recommended discharge instructions, and maybe we would recommend that you go to the nursing home or something, but we weren't in charge of coordinating that. You're on your own, right? The doctors didn't coordinate with each other. The hospital didn't coordinate with the doctors' offices. We didn't share information with each other much. Now, the doctors in our case could get information out of the hospital system, but we couldn't talk to them back and forth. We couldn't get their information. And you know what? There's actually a syndrome, a disease of the elderly called polypharmacy. I'm serious. It's because they're going to multiple doctors, and each one of them has prescribed a drug that's more or less the same activity of a different sort. And all of a sudden they're taking 3 or 4 things that are either are working against each other or cause you to be sick and not well. That's because nobody's talking to each other. So that's number one in Grand Junction. They coordinated the care. Number two, all the doctors in town agreed on certain treatment protocols, that everybody would follow the treatment protocols, so you didn't have people doing things that weren't proven in the literature or by empirical evidence to be a good practice or the best practice. That's huge. And then they did something that's really big that they had never lost control of, but everybody else had. They got back to having the primary care physician in charge and not free-for-all. That somebody was watching over everything that was happening to you. Doesn't mean that they didn't send you to the cardiologist when you needed to, because they can't do or maybe didn't want to. But having said that, they kept close watch on what was happening when that happened. And the other thing is they all had electronic medical records. Hospital, doctors, and they were all connected together so that they could share information. Those are probably the key points. And if you look at that landscape, there's not a single one of those things that we couldn't do. Not one. Some were costly, and some were politically difficult. But so here's what we did. The first thing I did was, we have one group of family practitioners that has about 7 or 8 people in it. So I thought, let me try this out on them. And I took them out to dinner, Pavillon, and I asked them, had you ever thought about any of this stuff? And I was amazed they had. It was like, oh, I've hit pay dirt, because they could help me spearhead this thing. And it started that small with just one meeting with a group of guys in one practice, and pretty soon it spread out, it spread out, it spread out. And this thing happened. It was like amazing for me to watch, because you ever seen birds fly off the beach? You know, it just sort of happens. All of a sudden, they all get it for some reason, and they're all... That's doctors. They don't pay attention to anything until they pay attention to it. I know that sounds silly, but it's true. So all of a sudden, they all figured out that they needed to do this. Or they were afraid of being left out of something, even if they didn't quite understand it. So the first thing that we did was we researched, and took a while, and purchased a brand new electronic medical record system, and $30 million and counting. And we also, the physicians, almost all of them now have electronic medical records in their offices. They hate it. It's a time suck that really ruins. Healthcare is the only thing where the computer ruins your productivity. It doesn't improve it. But it's a price you pay for having the data and being able to share the data. So we have a new electronic medical record system. The doctors have it. It's a really rocky road to get it started. It's still not where we want it to be by any means. But over the course of the next year or so, we are going to be interconnecting all of the offices so that we can talk back and forth to each other. And we also bought another piece of software that I'll tell you about a little more later, but it's really going to be the superhighway that lets us hook everything together, regardless of what brand system anybody's got. But it has a really nice feature, and that is, no matter what the doctor's office system is, what brand it is, this thing will allow a little icon to pop up on the page they're working on. And if it's flashing, it's telling them that in the interconnected world, somewhere in the system, there's a new result they don't have. And they'll be able to click on it, and if they want to import it because they think it's important, they can import it into their record. So that's really big. Alone, if that's all we were doing, that is a job of a lifetime to manage through that. And so number 2, we formed an organization called First Coast Health Alliance, and it's a 50-50 proposition. It's a separate company, and it's 50-50 owned by the hospital and the 200 physicians that joined it. So virtually every physician, with a handful of exceptions, joined it. And together, remember what I said about Grand Junction? Together, what we have pledged to do is to follow certain quality protocols together and meet certain quality targets. We're connecting ourselves together. We're going back to having the primary care docs, they call it medical home, is the lingo for it. Have the primary care docs be the leaders in charge of coordination. And we're adding stuff that, on top of that we never had to do. We now have to take care of what happens once the patient leaves our walls or isn't in the office. We have to the high-risk patients, we have to follow them with, give them their own personal health care coordinator. In some cases, heart failure is the number one admission for elderly people in Medicare. And Medicare is now going to punish hospitals financially if they have too high a rate of readmission of heart failure patients, if you exceed some rate. So think about that. We have nothing really to do with what happens to that patient after they leave. Nothing. The hospital, no. But now we do. I mean, I think that's crazy, but from Medicare's point of view. But we need to change the system anyway, so I'm not sweating that. So together with this organization, we're going to hire, we've just started, we're going to hire care coordinators. We have already stratified the patients so that we know which ones are the highest risk. We also did this. If you go over to the campus in the Whetstone building, you'll also see a sign on the top of it that says Borland Groover. Some of you may know who they are. They're a GI practice. Well, one of the leaders of the practice is named Dr. Jack Groover. He's a wonderful gentleman. And he and I were visiting one day, and he said to me that, you've got all this stuff going, and you've built this infrastructure, but you got to have a piece of wood to whittle on. You got to learn how to do this stuff. So what we did was I went to see the head of Florida Blue, and I said, look, I'm tired of this nonsense of us being like in a contest of some kind where we sit down and threaten to quit because you're not going to pay us enough and all that crap that we've been doing. We need to be partners. And that was important to me because guess what? The insurance carrier for all these large insurers that are self-insured except for mine, and we're switching, is Florida Blue. I mean, to the people that work in the school system, they think they have Blue Cross insurance. They don't really understand the concept of self-insurance, although Joe did talk to him about that recently. But that's the big partner. There's nobody else. So I thought, well, let's be partners. Pat, Garrity. And I knew he'd be receptive to it because he had just come from Minnesota where he had done that, where he had been doing that. And they don't understand their place in the world going forward, so they're anxious to try anything to keep involved. So we have a 3-year contract with Florida Blue, the First Coast Health Alliance. And the way it works is any patient that has Florida Blue, not just the self-insureds, but the Flagler College and the DMB school and all the other people that have it, I forget all of them, but almost everybody's got it. If you are an ascribed patient of one of the primary care doctors in our network, you are currently being covered under what I'm about to describe to you. We know what the spending was per member per month in the year 2013 of all those people. And what we pledged to do in the contract is to keep the cost of care from growing. And we have to meet quality targets. We have to meet the quality targets or the other part of what I'm going to tell you doesn't count at all. So it's all about quality to start with. If we meet the quality targets and we meet the targets financially of controlling the cost of health care for that group of people, the doctors get to keep half the savings. And I didn't take any of that money because I needed the doctors to have a big enough pie so they felt like they had been rewarded for changing their behavior. If I took money out of that and they only got like $800 each or something, it would be, well, what did I do that for? So I wanted them to be incentivized to do it. In the hospital, I won't explain it because I don't have time, but we'll get our money back in a different way, but that's already, the doctors are going to help us do that. But having said that, think about that. Oh, by the way, we also have a contract for 3 years with Medicare to do the same thing. So if you take all the Blue Cross patients and all the Medicare patients, that's probably 80% of our patients, inpatients. So that was important to do because you can't change your mind. If you're going to really think different about how you're going to practice as a physician, you can't say, oh, they're Medicare, I don't have to do it for them, or oh, they're Blue Cross, I don't have to do it for them. It's better to just have almost everybody in your practice be covered, and now you've got a different way of going at it. Now, I have to tell you, that sounds like, may not sound like much. This is huge. Think about the difference. Think about the incentive. The incentive is not to order that CAT scan when a regular X-ray will do. That's my best example because I've already watched that happen. We started in January, and the number of CAT scans is going like this, and the number of regular X-ray films is going like this. Now, what that tells me is, it's not that the doctor was being negligent or anything like that, but he was just thinking, I'll get a little better information off a CAT scan, and they got insurance, right? Now he's thinking, well, I can get enough information adequate to my task by doing a cheaper film, right? And costing the whole system less. That's huge. And the other thing is, they've never had to do this before. Now the doctors have to think about what the other doctors are doing, right? They can't let some rogue be out there not behaving, either for quality or not getting with the program about cost reduction. So someday the rubber will hit the road with somebody. But I have to tell you, I'm really energized about it because I think the doctors are excited about this, honestly. It's a different playing field. I think some of them are a little nervous, especially the specialists, that they're going to lose some referrals and things that they might have got. But I think, honestly, physicians make their referrals to other physicians because they have faith in their quality. So I don't think they have much to worry about in that regard. But anyway, that's really big. Now, we just got started. We're just about to hire care coordinators because we have identified the people that are at the highest risk of readmission. And they're going to get home visits. They're going to get whatever it takes. The medical director of the First Coast Health Alliance, think about this. Every year there's a 20-day benefit under Medicare for nursing home, for rehab, short-term rehab. When a Medicare patient goes to a nursing home, how many days do you think they stay? 20 days. So I'm sure if I ever had a nursing home, would I do that? No. So the medical director of the nursing home, of our medical director, is actually going out to the nursing home and looking at those patients and seeing whether they belong there anymore or not. I mean, we have to actually actively intervene in things that were not ours. We're going to have partnerships with home health agencies that we trust aren't constantly recertifying people for more than the length of time they really need, which I think is my feeling is that there's some abuse there. All of these things, every player is now a little bit nervous about where does this lead. Now, I have to tell you this. This is the conundrum for every hospital CEO. Think about what I just told you. The hospital is now not a revenue producer. It's a huge cost center for this system. And guess what? Admissions are going to go down. So here's a CEO making a strategic plan to keep patients out of his own hospital. I mean, what am I doing? And that's the problem. So we're going to have to do some balancing about other things. I would say this, that most CEOs of the hospital haven't really thought through whether that patient was actually a helpful addition of revenue or it was actually an expense. Because some of those CHF patients, when they came back, you didn't make any money off of that. So the fact they were laying in the bed made you put an extra nurse on and all the rest. And there's a bad habit in doctors, which I hope this whole system will help erase, and I call it the Wiley syndrome. You know, you come in for a broken foot or something. Oh, while she's here, let's work on her whatever other problems she's got, even though that's not what they were there for. And that's thoughtlessness about spending. And I'm going to leave that particular subject and talk about something else, but I want to talk to you about something very serious. This is so difficult. The hospital has to kind of stay away from this because it would be, our motives would be misunderstood. But I'm very passionate about this myself because I have an elderly father-in-law and I've watched the system work on him. Half the Medicare money is spent in the last year of life. And most of that is spent in the last 3 months. Now, what does that tell you? It tells you that that was thoughtless, futile, harmful care, most of it. You're really not doing that person any favors. Most people don't understand that some of that stuff we do hurts. Even being resuscitated, people don't, they watch it on TV, they think it's just these paddles and stuff. In real life, I don't want to upset you over your lunch, but you can hear their ribs crack. I mean, it's not nice. So some of this stuff, feeding tubes, horrible, horrifying. The stuff that we do are fine when they have a curative purpose. They're fine if they have a making somebody comfortable purpose. But when the patient is incapable of being cured and they've reached the end of their life, we're not doing them any favors by doing that stuff. We're doing them a favor by keeping them comfortable and pain-free and, you know, even mobile if that's what's necessary. So I'm not saying you don't do, there's lots of stuff you do. You just don't do bad stuff. And you just have to say, stop. And you know what? It's not going to be us that pulls that off, I'm sorry to say. The physicians just were trained that death is a failure. I mean, they are. Some very thoughtful physicians get it. And by the way, there are articles, there was a Wall Street Journal article, that doctors don't do that to themselves. They don't die that way. They don't make those choices for themselves or their loved ones. We all have to change. Our expectations have to change. We have to say, no, I'm not going to do that to my father-in-law. I'll just give you a real quick example. My father-in-law has one leg shorter than the other from World War II, and as age has come, that's been exacerbated. You'd never notice it, and now he has a horrible gait. Can't really. At this point, he's in a wheelchair, but he wasn't. He was walking with one of those 4-point canes, and he was falling all the time because he didn't have the strength to use that anymore. I got delegated to go up to Virginia and tell him, because I'm the guy, I got delegated to go up and tell him, that's not going to work anymore, Larry. You need to get a walker. And do you know how hard that is for an older person, especially the men? That's an admission of you're on the road to death, especially if you live in an assisted living facility and you've watched. As soon as they get that walker, man, you can start the clock. And that's what's in their head, so he wouldn't do it. Guess what? He falls down because he has a terrible gait. He can't walk. No other medical reason. So he broke his rib. I have no idea why they took him to the hospital. They have a perfectly good medical wing in this place, but they did. There's no treatment for a cracked rib. You don't do anything. You used to put a binder on, but you don't even do that. Pain medicine. Then they admitted him. Why? Well, that was a mistake. And then once they had him and they see, oh my gosh, we call it syncope. That's dizziness. We get somebody who fell down. They decide, oh no, now we're not going to get paid for anything. We got to work this up and find something that we can get paid for. I know that's what they were doing. So neuro workup, cardiac workup. And before I could intervene, here's this cardiologist wants to put a pacemaker in a 90-year-old man who's demented. And she argued with me about it. I mean, no. Are you kidding me? So I want, there's a new, I had told you that for a purpose, because there is going to be a community effort soon that you'll see and hear about. And there's a much more thoughtful kind of a living will that takes you through scenarios about what you want at certain periods, because it's going to change in times of your life and the condition you're in. And it asks more thought, and a trained person does it with you. They ask you more thoughtful questions, like if you don't know who you are anymore, or you can't recognize your loved ones, do you want blah, 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 blah. And the answer changes over time. So periodically you do need to sit down and think about that, if you've got one already, what you want and what you know. I have to tell you, though, because I also had a family experience with this, that the death scenario for most people involves multi-organ system failure. It's not one thing. And living wills think about the heart stopping or being on a vent or maybe a feeding tube, but they don't think about the extraordinary measure is really an antibiotic. At some point, they used to say pneumonia was the old man's friend. It still is in some circumstances. And you just don't want to do that, because you're not prolonging life, you're prolonging death and the death process. And that's an ugly thing to do to people, and we need to learn not to do that. And I don't mean assisted suicide or don't misunderstand what I'm saying. So there's that, and we'll never conquer the cost curve unless, as a society, we change that. So having said that, that's my preachy thing. The other really big thing that we're doing, and this started 5 years ago too. Hugh Green is the CEO of Baptist Hospital, and he's been CEO there for 20-something years. And he and I have known each other all that time. And we're sort of the deans of the hospital CEOs, because everybody else is fairly new. And we would get together just as colleagues to chit-chat about what the world looks like and what are you doing and what are you doing. And we started talking about, here's what we woke up and realized. I mean, we both kind of realized this all at once. If you look around the community and you go south of here, what you'll find is what? The Seventh-day Adventists for Florida Hospital. Everything until you get to Halifax, they own it all. Ormond and all that. And guess what? Where is that? Where's the control of that? In Orlando, not in Palm Coast. They may have a board at the hospital in Palm Coast, but they don't decide anything. Everything's decided in Orlando. If you go up to Jacksonville, you have St. Vincent's, belongs to Ascension Health. It's the largest Catholic hospital system in the country, and it's based in St. Louis. And guess what? All the decisions about what happens at St. Vincent's in Jacksonville are made in St. Louis. And small ones are made in Pensacola. But they're not made in Jacksonville, and that board decides nothing. Moody Chisholm is the CEO of St. Vincent's, and he's on the phone every day to St. Louis. And then there's HCA, of course, big national company, Nashville. They don't make any decisions in Jacksonville. None. That board decides nothing. They have one. And so then of course you have the university associated chance, which is a different kind of animal. And actually, even though they'll say this isn't so, it is. Decisions are made in Gainesville. So the board of that hospital, what do they decide? Nothing. The decisions are made in Gainesville. So who's left? Baptist, community board of regular community people, mostly successful business people, some, doctors and a mix of people that you would typically see on a hospital board. At each of their associated hospitals in Nassau, all those people are from Fernandina or that area. They're all just like regular hospital board members. At the beaches, same thing. Guess what? They make the decisions. The community people on those boards, just like a church vestry, they're making the decisions, not someone else who doesn't know the community or what's going on or anything like that. And Hugh and I think that's special. And we don't want to lose that. Now, you may think Baptist is a big system, and maybe it is relative to Flagler, but it's not. It's a puny system to Ascension Health or Inova in Virginia or any of these places. I mean, it's small. It's got 1,000 beds in the system. Well, guess what? Florida Hospital in Orlando's got 1,500 beds just at downtown. Never mind all the rest of the stuff they got. So it's a small system. And size is going to matter when we get into this new world. And the new world is going to be, we're starting out with trying to save the cost increase with no penalty if we fail. We'll still get paid. The next phase is what I call capitation. It's where Medicare says, here's the money, you go figure it out. You've only got this much money. That's called capitation. You get paid so much per member per month, that's it. You live with it, you figure it out. Now there's risk there, right? You've all of a sudden become the insurance company, in a way. Now I'd rather control that money in First Coast Health Alliance than have Blue Cross control that for me and take a profit off the top, right? Waste that has nothing to do with patient care. So all of this is in preparation for that day. And Hugh and I both believe that day is coming. Maybe not while we're in the chair, but we see it coming. And if you're going to do that, you got to be big or bigger. And we were natural partners because I know you'll understand this being faith-based here. We actually have a mission, and we believe in it. And it's, taking care of the healthcare needs of our community. It's not about money. We have to make money to provide the care. We don't provide the care to make money. It's a very different mindset. We're not like Ascension Health running a big financing thing with hospitals as a sideline. And we're not. And the local people that run it are so similar, and our cultures are very much the same. And you wouldn't want to get mixed up with somebody who had a different culture. That just would never work. So we were having those conversations, and we couldn't quite figure out what to do. And we looked at each other one day and said, you know what, neither one of us is a lawyer. Let's go get one. So we hired a lawyer out of Pittsburgh, well-respected healthcare firm. And we went to an undisclosed location because Hugh and I couldn't be seen together. Can you imagine? So we hid in this conference room, and we had a whiteboard, and we threw out ideas, and the lawyer was very helpful. And essentially, and we got pretty far with it. And then Hugh called me up one day and said, I want you to meet somebody. We were always looking for a third partner. And I'll be honest with you, primarily for the optics, because if I didn't have another partner in this, you would all think that Baptist is taking over Flagler, and it just isn't so. But with a third partner, it makes it more obvious that that's not the case. So he kind of wanted to do that too. But we had to find the right partner if we could find one. Well, it just so happens that in Brunswick, Georgia, Southeast Georgia Health System had opened a satellite clinic of Wolfson's Children's Hospital there. So he had been, more connected to Baptist than he'd ever been before because of that experience. And he actually just asked Hugh one day, have you ever thought about having a partner? And Hugh called me up and said, if not, would you meet with this guy? Because if nothing else, he's a heck of a nice guy. You can't walk out of the room not liking him. It's like if nothing else happens, which was true. He was a heck of a likable guy. And he came down to visit me one day, and when we got up to leave, it was like we could have gotten in our cars and driven to each other's place and not known the difference. It's like we had the same problems, everything. It was scary. But again, their culture is so much like ours, same thing, community boards, they're 316 beds, Flagler's 335, Baptist system is 1,000. Together, we haven't quite doubled Baptist 1,000, but almost. So just think what that can do for just buying stuff alone. Never mind all the other things that we can do together. So what we wound up with, and here's the only analogy I can think of that maybe people can grasp, because it's a hard concept. It's not a merger. It's not an acquisition. We are not changing anybody's name. We're not putting anybody's money together. We're not pledging each other's debt or anything like that. It's not. There's no financial affiliation whatsoever. It's more like this. The NFL has, 30-something teams. And you have the Owners Association, right? Well, the teams all have their own names. They run themselves. The Owners Association has nothing to do with running the teams. But they can say, no, you can't sell it, or no, you can't sell it to Rush Limbaugh, or whatever, right? And they manage the TV money that gets spread around, and they also have they decide on salary caps and, strikes and that kind of stuff. So that's what I would call reserve powers. But the reserve powers are there, but they're about extraordinary things. They're not day-to-day life of running the team. And I suppose if you had a team that started to go down some really aberrant road that made them uncomfortable or was a risk of reputation or something like that, they might intervene. Well, we saw that in basketball, right? But technically they probably have no right to do that. But having said that, so these are reserve powers that are really quite invisible unless you're going to do something really dramatic. So here's what we did. We are in the process of creating another company called Coastal Coastal Community Health, excuse me. And it's going to have a board of 12 members with representation from Flagler, representation from Southeast Georgia, and representation from Baptist. And that company has some reserve powers over all of us. So it's not Baptist buying anybody. Baptist is actually giving up a little bit of control to another company that they don't completely manage. So I think everybody needs to understand that this is a brave step for all of us, and it's a measure of how much we trust each other that we would even do this. I would say this: we've spent a lot of time in the preparation for this, having our board members meet each other, have our physicians meet each other, having our management teams meet each other, and I have to tell you, we're all the same. Every board member walked out of that meeting thinking, well, they're just like us, all of them. So the sense of mission and the sense of community and the sense of same culture gives me a good feeling that this is going to work. Right now what we're doing is we're doing some behind-the-scenes legal work to get the thing done. But also we have our management teams in 12 different groups sitting down with each other saying, what could we work on? Let's have some ideas about things we could do together. And I don't take this to the bank, but this one it just jumps out as obvious that I'm quite certain you'll see someday. But think about this: if Southeast Georgia can have a satellite Wilson clinic, why can't we? We can have that too. It just so happens that when I go to these meetings, the 3 CEOs, we've been meeting almost every week for the last year and a half or something. It's getting tiresome. But I have to go to the Aetna building downtown Jacksonville because that's where Baptist headquarters is, and it's halfway in between for the two of us. And guess where the pediatric outpatient clinic is for Wolfson's? In the Aetna building. I run into Dr. Chu, the guy who used to run the program, in the elevator almost every time I go there. But you know what else I see? I park in the parking garage, and here in the car next to me is some poor mother struggling with some kid with a great disability in a wheelchair and getting them out of the car and into the wheelchair. Imagine if they didn't have to make that trip. How much better that would be for them. Imagine how much better it would be think about this. I guarantee you there are people in Palm Coast and Palatka are also making that trip because the nearest other children's hospital is in Orlando, real children's hospital. And they're not going to drive to Orlando. So there's a lot of people wouldn't have to make that trip or make an easier trip. So I think that's a simple thing that just right off the bat we can do. And it's not, I want to give that example because it's not a buying club. It's not a Sam's Club of hospitals that we're just going to get stuff cheaper. Really, there are going to be real benefits to our communities out of this, or we're not doing our job. So that's what I wanted to tell you about. It's a whole new world. I never thought that at this stage in my career I'd be reinventing healthcare, but that's the job God gave me, and I'm going to do it. So thank you very much.
Wow, that was a lot of information, but a lot of good, exciting things happening. I'm so thankful that I'm in St. Augustine and have this man overseeing the hospital here. That's exciting. That's exciting.